Dr. Lipkin, thank you for joining me on this JawCast episode. We had a live interview a couple of weeks ago. We got some feedback on that. You wanted to come back on today to address some specific questions that arose in the comment section of that interview that was posted in January.
Hi, Euron. Yes, I just looked like there was some confusion. So let's just go right to it. They'll talk about asymmetries. People always are scared of asymmetric expansions, and there are a couple of different things about asymmetry. Some patients are naturally asymmetric. Actually, we all are naturally asymmetric. If you take two mirror images of each patient's half and put them together, you'll be looking at a picture of two different people. And some of those asymmetries are subtle, and some of those asymmetries are really significant. So when we do the expansion, if it's done properly, again, in my hands, I'm not talking for anyone else, it's just from what I've done and what I've seen from others. At least that's my conclusion. It's not research-based. It's just purely, one-man study. So most of the time, when there is an asymmetry, it will always be exacerbated by expansion. There will be some changes in the bite that will change your face. If the bite opens, the bottom jaw drops down a little bit. That changes patient's face. For example, if somebody is very, very skinny, when expansion starts and the bottom jaw starts dropping down, you increase the vertical, that will be much more pronounced, like the cheekbones and so on. If somebody is really asymmetric, that asymmetry will really be magnified. It's not asymmetric expansion, it's just patient's natural asymmetry.
Why does MSE tend to exacerbate asymmetry rather than, say, the side that's less expanded? Why wouldn't it expand that side, and why does it tend to take the side that's already too big and make it bigger, and vice versa?
It's just if one side is already bigger and one side is smaller, then as you expand it symmetrically. But one side that's bigger, it will look more pronounced. Again, you stretch the soft tissue as it changes some bite dimensions, and when that happens, the side that's more off will look more off. It's if you look at the original, let's say where you start, the expansion goes symmetrically. It makes it look. If you are already asymmetric, it'll make you look worse. That's why a lot of asymmetry cases, should be complemented by surgery sometimes. There's also a couple of different asymmetries. Sometimes asymmetry could be just general asymmetry, which is kind of mild, but sometimes there could be substantial asymmetries. First of all, they will be significantly magnified, and those asymmetric cases will very likely, very often, may require a surgical correction to really address it.
So when you say surgical correction, are you talking about they would do like an MMA surgery? And can you describe what a surgical correction of asymmetry involves?
It depends where the symmetry is, right? So let's say if the face is more, fairly symmetric, just maybe like a little skewed like this, very slightly, or just one side just slightly smaller, one slightly bigger. Sometimes it could be the whole thing skewed. Sometimes it could be just let's say it's an upper jaw symmetry and the lower just fits into it. Sometimes this could be a lower jaw symmetry. So there are multiple layers to the asymmetry. So essentially, let's say one side of your face significantly smaller, then during the surgery, whichever that would be, MMA surgery, lower jaw advancement, upper jaw advancement, whatever. Aside from bringing the jaw forward, they could sometimes either bring one segment a little bit more forward, or sometimes if it's a maxilla, they could maybe add grafting material to a cheekbone to make it look more symmetric. Not that they're going to make bone symmetric, but at least a good surgeon could make the upper jaw more symmetric. If someone's got a lower jaw is completely off to the side because the condyle is very short on one side, that again, it would require a lower jaw change where they got on both sides, but they'll rotate it more to one side to center it. So that's how they usually address those asymmetries during surgery.
Now, what about in a patient who comes in fairly symmetric, not perfect, no one's perfect, then they do an MSE, and now all of a sudden, bam, there's a big asymmetry that seems to have come out of nowhere. Yeah. Do you agree that MSE can actually cause an asymmetry where there was no asymmetry that existed before? Not the appliance inherently, but maybe let's describe it as a misuse of the appliance? or an incorrect application of the appliance?
In my personal experience, again, not talking for anyone else or for any kind of research, from what I have seen, any asymmetry that was caused in my early career or something that I've seen posted in the Facebook groups or other groups I'm part of, it's always an incorrect installation or incorrect planning of the MSE placement. So let's say, for example, sometimes you may have maxilla even, but the bite plane is off, right? So if MSE will be installed, parallel to the palate, it will still expand symmetrically, but then you have to address dental asymmetry. But sometimes if the palate is this way and MSE installed that way, it will pull them this way. It'll pull them in the opposite direction. MSE is stupid, doesn't know any better. It'll just, push things sideways. And again, from what I've seen in my personal experience, whenever the MSE ended up set incorrectly, and it's usually most of the time a lab error, then you ended up with an asymmetry, and that's my personal experience.
Doctor, I think we're going to have an issue with all the opponents of MSE after this, because you just gave them a really bad quote to use against us. You said MSE is stupid.
Sorry. Well, it's the doctor who's got the brain, right? So, it's, MSE is a tool. MSE is that's nothing else but the tool.
Right.
So
right. No, I know exactly what you meant.
Only if you can get a hammer or and start putting nails everywhere, and if you don't know what you're doing, you'll screw it up. So it's the same with an MSE.
Right. All it does is it just goes left to right. That's it. Wherever you put it, it's going to go left to right.
That is correct.
So, for example, I had a guy on my channel a couple of months ago, and he was on his second MSE, and he had done like 16 millimeters of expansion. It was a lot, and one side was completely out in left field. Had no bite at all. I mean, it wasn't even close to a bite. There was zero contact on that one side. And then the other side was like, okay, there was a pretty solid bite. It was not as aggressively expanded at all. Out of, say, 16 millimeters, let's say 12 of them went to one side, it seemed. So what do you think happens in cases like that?
So two things could be happening, okay? So when you overexpand, let's say initially when the arches are coordinated and you start overexpanding, what ends up happening is the body, our muscles they want teeth to touch. That's their natural program. In the kids, for example, who's got a bite issue and width discrepancy, the lower jaw will always shift to such a way that some teeth will be always in contact. Very often, and I've seen this with the MSE patients, again, from other practitioners, where there is an overexpansion, and it's a natural, the orthodontists call it a functional shift, where let's say when you expand, even though you may be expanding symmetrically, but your lower jaw will always track one side. It's uncomfortable to fit inside. It's not stable. So the body, quote unquote, is looking for stability. A lot of times, if the patient shows you, okay, I'm biting on one side and there is none on the other, that's not a very good way to check it. So essentially, we need to. That particular patient needs to be examined in such a fashion to make sure that the jaw joints are centered. And very often, more often than not, if you overexpand the top and the bottom jaw is centered properly, the lower jaw will be, somewhere in the middle of that expansion.
Right.
Now we need to basically expand the lower to catch up, or somehow one way, whichever way, to catch up to that overexpanded upper. That's one situation. Another situation, if the MSE was installed in such a fashion that it's engaged, let's say, a nasal septum on one side and then the other it did not, that you could also produce unilateral expansion more so on one side than the other. But that's just a purely lab mistake or practitioner's mistake. It's a artificially caused asymmetry, not a symmetry that's was created by MSE per se.
Can you explain the anatomy of that a little bit more, about what happens when the TADs end up in the nasal septum and that causes one side to go and the other side not to?
So we have the upper jaw that has two halves, and the septum is in the middle. So when everything is installed properly and symmetrically, it splits right under that nasal septum, right down the middle. When the MSE is not centered properly, and let's say it's skewed, or it's let's say one side goes into the nasal septum, it may still split. But now you anchored this half to your nose, and this half is more free floating. So now you're getting an asymmetry. Right. But again, that's caused asymmetry artificially, not because some other factors.
I think there's a lot of confusion with people about the anatomy of the nose in particular. So just to be clear, the nasal septum is a bony, it's like a cartilage. It's a bony cartilage, mass. And so the TADs actually are colliding with the bone of the nasal septum, the cartilage of it, and then pushing on the nasal septum does not result in expansion? Sometimes
you may still get an expansion, but you will get a symmetric expansion if one side is locked more to the structures above it other than only maxilla.
Right. So the septum becomes just an additional anchor, additional resistance point that causes that side to... Or you could even say that the septum absorbs the force of the MSE instead of the maxilla absorbing it, and so that side of the maxilla just doesn't move as much because the septum is absorbing it. Essentially,
if you do symmetric, you're getting symmetric expansion. If you get one side, I'm exaggerating, so you got like this, so now you got this whole side of your face and the nose pushing against one side of the maxilla. So obviously that side will go further out than this side because there's a lot more resistance on that side.
Wow. Yeah, that makes perfect sense. So in the case of the first type of expansion where there's just overexpansion and then the lower jaw looks for home, and it's not a good home.
That's said very well.
Yes,
it's looking for a home, exactly.
It's looking for a home. Well, I know what that feels like. Is that just an inherent part of MSE treatment, or is this a mistake to allow this situation to occur in the first place?
I think it's just a poor planning. Not necessarily a mistake, just this, upper obviously is going to go much faster than the lower. So if you either anticipate that to happen and you tell that to the patient, okay, we're going to expand you 16 millimeters, but the bottom, let's say if we do SFOT to catch this up, it's not going to move as fast. So you pre-plan for that, and sometimes you would need to give a patient some sort of an orthotic to keep the lower jaw centered so it doesn't look for home.
Right.
So challenging with the expanding upper, but still not impossible.
Right. You know what's an analogy? It's almost like a kid who maybe he's lost his parents. He lost the left and the right side. And so what's he do? He looks for a father in the wrong place. He hangs out with the local drug dealer or whatever, the gang leader. He's just looking for help somewhere and guidance. He's looking for contact. So it swings over to that one side. So you're saying you have to plan treatment to coordinate the upper and lower expansion together somehow. That's not easy, though.
It's not easy, but it needs to happen. It's because essentially, if you're expanding the top, you need to. That sometimes puzzles me actually, because I've seen cases where patients, when some practitioners present things, and they achieve this fantastic expansion, but they've never planned for anything else. All right, I've got the expansion. How? But it's just a part of the treatment. You need to you need to plan everything else. So that's why sometimes I have a couple of patients right now, our mutual patients, friends, so to speak, that I told them, look, we can only go to this point, and then one guy said, well, I want more expansion. I said, well, you can get more expansion, but you need to consider what we're doing on the bottom. You will not have the bite. So it needs to be addressed before you ever start.
Right. It's almost like with the town fair where they have the biggest pumpkin competition. It's like you can try to make the biggest pumpkin, but it gets so big you can't even put it in your truck anymore. And what are you going to do with it? You can't cook it. You can't make a jack-o'-lantern out of it. You won the prize for the biggest pumpkin, but now you have new problems. So do you think that, and I've asked you this before.
Yes. Hold on one second.
Of course.
Somebody came. Hold on one second.
So I'm going to take this opportunity to show off some new JawHacks merch. This is the new iPhone case from JawHacks. It says they're called wisdom teeth for a reason, with the dope JawHacks logo showing the MSE split. You can get this for your iPhone or for your Samsung Galaxy phone. We've also got t-shirts, a hoodie, and a dope hat that you can check out in the link below in the merch store. Show it off to your friends. The cool thing about the JawHacks bling is that it's so well designed. Even if people don't know what JawHacks is, they'll still think it's dope gear. Check out the link in the description. Get 10% off with the code and enjoy your JawHacks bling.
All right, I'm back.
So, Doctor, I've asked you this before. Don't you think that mandibular midline distraction could be a good solution for coordinating upper and lower expansion in cases where someone really wants to push it and get, 10 plus millimeters with an MSE?
Sometimes it could be a possibility, but it should be very, considered very carefully with a very good experienced person. And I have never done one, but from what I've known, it is sometimes what happens when you split the lower jaw this way, you're changing this whole part out. You're rotating it like this, but you're rotating it around the jaw joints. So if your joint sits like this and it starts twisting, you may create a serious TMJ problems with doing the lower midline STI, cutting in the middle and making it wider. So I would much prefer to do either SFOT or coordinate it some other way. That I will not be very comfortable.
Yeah, you don't think that that's a terrain you're going to travel down? You're not going to venture into that forest?
Well, I would. No, I won't.
Yeah,
it's just too much danger in that forest.
Yeah.
So I would much prefer something that I'm familiar very well. There's different ways to make the lower arch wider safely without doing, causing possible damage to the jaw joints. Because once you've done that, then you're in a deep forest and you lost.
100%. Yeah, the TMJs are very finicky, and sometimes it's better to just let that dragon sleep.
That's correct.
And so what are your preferred methods for having the mandible keep up with the maxilla in an MSE expansion case?
So there are two different ways. First of all, a lot of times the lower arch, when the upper maxilla is narrow, lower arch is always, back molar is always tilted towards the tongue. And there's actually, it's called curve of Wilson. So if you put a curve, around those molars, it's going to look like this. So just uprighting those molars will give a lot of width to the lower arch. Mm-hmm. Sometimes, again, if you look at the lower jawbone, if you slice it through one side, it's not like this. It's very often wider on the buccal side of it, right? So if you do a lower uprighting and intrusion, let's say with the TADS, you can also go into a wider base of the bone and also keep the teeth in the bone that way. Mm-hmm. In addition, obviously SFOT, grafting, definitely. Also in MMA cases, for example, if you want to get this much expansion and then your lower needs to catch up, so in addition to SFOT, you can also drive the lower arch back, essentially increasing the overjet for better surgery. But the lower jaw in the back is much wider than in the front. So you're essentially taking the teeth and you're bringing them into the wider arc. When eventually lower jaw will come forward surgically, it will fit with the wider upper.
Is that why in some cases the surgeon tells the patient that they want to extract lower teeth before surgery?
Before TADS is very often what was the only option, correct. Mm-hmm. Now with the TADS, that's not necessary.
Which is to say that you can move the lower teeth back without extracting lower teeth?
Exactly. You could put two TADS on the sides. There's something called buccal shelf. So you could put TADS on the side of it and literally bring the whole arch back.
Wow.
So this way uprighting the lower front teeth as well.
What percentage of your patients do you send in for SFOT?
Whenever it's necessary. I wouldn't quote on a percentage. Probably fairly small.
Yeah. There's so much concern that patients have about how their mandible is going to keep up with their maxilla, and I tell them 99% of MSE cases are done with no special help for the mandible. It's just tooth-borne expansion and tipping of those teeth, and it works. I think everyone assumes the worst, and they think, oh, I'm going to need some sort of surgical intervention to help my mandible keep up with my maxilla. Do you think that a lot of that just has to do with people wanting to overexpand? For example, with this patient who did, 15 millimeters that I had on my channel, is that just too much?
It depends. For some people, it could be too much. For some people, it may not be enough. I have a kid who had such a severe discrepancy. He's a surgical case. He's a severely narrow upper jaw. It was 25 millimeters in width. I had to put two 12 millimeter expanders to get the upper to fit to the lower.
Wow.
So post-surgically. So we've had a 20 millimeters expansion, but for him, that was from severely constricted to normal. Mm-hmm. For somebody who is, borderline normal wants 15 millimeters, that's absurd. They're going to look like, they're going to look hideous.
Yeah.
So, just because you can get something, it doesn't mean you should. It has to be, again, everything has to be pre-planned.
Now, moving on to the second type of asymmetry, the kind that's caused by misplacement of the appliance. Mm-hmm. Can we talk about how that's avoided? You showed me when I was in your office, you showed me a ceramic mold of a maxilla and an MSE that the lab had sent. And you said, you see that, Ron? And there was just a little bit more space on one side than the other. The appliance wasn't perfectly seated on that model. You said, you see that, Ron? I double-check every MSE I get, and when I see a discrepancy like that, I send it back. So it's a kind of quality control. Can you talk about this?
Initially, what happens? Let's say right now, I'm either planning MSE myself if it's a younger patient, where I know I'm going to get the expansion. Then I pre-plan it on the cone beam. I pre-plan it on the model. I check every step, making sure that everything's parallel, that I don't get asymmetry. Because I had patients that come into me and they say, "What if I'm going to get a symmetric expansion?" And I always told them, again, purely my patients, that you will not get a symmetric expansion because I make sure that everything sits parallel. If I know that it's going in parallel, in my mind, it should stay parallel. So some cases, with adult cases, I used to customize them myself, and you've seen some of those. But now that I have, worked with labs like Dental Partners and lab, they have really great 3D planning software where I could pre-plan and making sure that the pads are going in the right place. However, you always have to remember that final steps of assembly is done by a tech. Technicians, as much as wonderful as they are, they're not doctors. Sometimes they could put things together and say, good enough. Or maybe there was a cup of coffee that he spilled at the time of putting the plan together, and something ended up just a little bit crooked, but that little bit crooked could translate to a lot of crooked in the face. So even if something triple digitally designed on the model, is still, when it gets to your hands, you need to verify it and look and examine, because sometimes you could have a bite plane that's even and you want to keep it that way, but your palate could be canted. So and I've seen this happen, a digital lab installed the screw parallel to the palate, not parallel to the bite plane. So, then I created humongous asymmetry because, again, it's an incorrect installation and the doctor missed it. And technicians, I've seen labs and other labs where they do fully digital design on the computer, and then the technician uses sticky wax to attach the MSE to the model. I mean, how accurate is that? All right. And the third thing, they could do a digital design with, let's say, conventional molar bands, orthodontic bands that require force to be seated, right? And they use something called bite stick to seat each band. So if the patient bites a little harder on one side and not so much on the other side, you're going to install that MSE crooked. So if someone's using conventional orthobands to fit the MSE, it's like a lot of little errors. They could go into this placement, and little errors could add up.
What percentage, and I ask you about percentages all the time, are you in a league of your own when it comes to this level of quality control? I mean, are doctors who take these MSE courses and learn to use this appliance, are they being taught about this level of attention to detail?
I hope so. I mean, I in my courses, I teach it. I stress it. But if as far as league of my own, not trying to create a league. You know, it was very funny when during our podcast you said that, you know, I'm top, like one of the better guys on the planet, and I misspoke. I said it's not, you know, I meant that I'm not the only one on the planet, but it sounded like I doubted the planet existence.
Flat Earth.
Flat Earth. Yeah, I read the whole comments. That was very funny.
Oh, that was funny. That everyone's just poking fun.
Yeah, I know, that was fun. But essentially, I mean, if you're a doctor, it's like that's what you train for, and these things you have to check. I mean, just you could stick the appliance into the patient's mouth, but you need to understand the little details. Absolutely.
Yeah. But, I mean, let's be honest. So you have some children, and if I had children, you would probably be very careful about who you sent them to for an MSE treatment, because you just know how delicate it is, don't you?
No, of course. Not necessarily delicate, but it needs to be done with proper planning. Everything is planning.
And, like, you just know that probably most of the people out there, most of the doctors out there are not checking things at the level that you are, and to ensure that this isn't happening.
I wouldn't claim that. I'd say I know what I'm doing. I don't know what other people are doing. I'm sure people who have less experience, they may be, not that they don't know it, they just may be overlooking certain things just because they're inexperienced. However, I'm sure there's plenty of people who do really good quality control and checking and making sure that everything is in the right place. I'm sure there are plenty of people who do that as well.
Yeah,
definitely people who take in my course.
Yeah, so about your course, I would love to take this moment to have you, you know, if you want, because there's a lot of doctors who watch my channel. Do you want to pitch that and tell people how they can access that if they want to sign up for your course?
If somebody is interested, my next one is March 4th. So they could send me an email, drlipkin@gotbraces.com. And I'll be happy to help. I'll be happy to send them the info.
So they come and they basically shadow you in person, and they watch you treat patients.
Well, they could certainly do that, but usually we put together a whole-day course where in the beginning, we review some basics, very important steps of how to plan it, and how to, if you're doing the actual MSE, and how to plan it with the digital planning. Spend a couple of hours in just discussing failures and how to prevent the failures from happening. Then we have a live patient demo where we place the MARPI or MSE and together with the PIEZO assisted. That's usually a couple of hours, and then I just present as many cases as I can to show them how it could be utilized properly and creatively and achieve the goals of treatment that they set out to achieve. So that's a full day, 8 to 6.
Excellent. Wow. And is it right in your clinic
right in my
Westwood?
Office, yeah. It's usually limited to about 15 people because that's all I could fit.
Man, I wish I could go to dental school and become an orthodontist and take that course and become a master MSE provider.
You're welcome to audit it at no charge. You're welcome to still attend it.
Thank you. That's very kind. I've audited courses like that before. I did Juan Moon's course in November 2021 in Cambridge, which was fun. You know, so I may take you up on that. No cameras allowed, though,
there
right?
Are no cameras. No. If you want to listen, if you want to film it, by all means.
I want to move on to the second subject that we should discuss today, which is face mask. So, doctor, tell us, there was some uproar. It was pandemonium in the comment section of our video. People did not like what you had to say about pulling down with the face mask.
I think the people who made the uproar understood what I meant. So you could direct the movement forward, upward, downward, but it depends on what you're trying to accomplish. People started picking at the one comment that really it depends on what you need to achieve. You have your 3D structure, and sometimes you want to rotate it down. Sometimes you want to rotate it up. Sometimes you bring it straight forward. Combination of all three, all of the above. So you could direct the pull forward, down, up. I don't usually when the maxilla is deficient from top to bottom, and maxilla is deficient from front to back, you want to pull it down and forward. If somebody's got a really high angle and already gummy, obviously you don't want to pull it up, well, usually if they're that gummy, they need surgery and then they cannot fix it. You cannot fix gummy smile with trying to pull maxilla up. You could intrude the teeth, reduce the gumminess, that you could do, but the base of the maxilla, it's under the base of the skull. So maxilla cannot go through the skull. It can only go forward or down. You could make the pull up to prevent, let's say, further extrusion. Yeah, you could do that, but it will not go up.
I think the confusion comes from, anyone who's doing an MMA surgery, they're going for counterclockwise rotation,
correct,
right? Which would be up, right? So I think, and correct me if I'm wrong here, I'm just telling you what I think, how people think about this and why it's very counterintuitive when they're told to pull down with the face mask. Everyone thinks they need to go like this. They need to go up and forward. So
they don't.
That's where the disconnect is.
Sorry to interrupt you, but essentially, unless the oral surgeon does the impaction when they remove the part of the bone and actually move the upper jaw up, when you're talking about counterclockwise movement, actually the maxilla moves down. Okay, the back of the maxilla goes down, not up. So and the front usually stays the same. Unless they remove a lot of, let's say if somebody's got a really high vertical and they remove part of the maxilla and they do the impaction, it's still a whole different surgery. But you can't do that with a face mask. It's wishful thinking.
So, right. So part of the problem is that it's just physically impossible to go up with face masks. But then you're also saying
you could intrude the teeth up. You could intrude the teeth into the bone to reduce the dental alveolar part of it, so teeth position, but you cannot intrude the maxilla.
Right. That's asking a lot. That's a big intrusion.
You could intrude the teeth, but you cannot intrude the jaw.
Because the skeletal bone doesn't change the way that alveolar bone does when you put orthodontic force on teeth.
Correct. You could move the upper jaw forward just because, upper jaw is like a pyramid inside everything else. So you could move it out, and down. You could not move it up. Only surgically you could move it up.
Right. So have you never even seen a face mask case where a patient where the maxilla was given counterclockwise rotation via the face mask? That just doesn't happen?
You still get some dental alveolar change, but essentially if you just put the force up, with the rubber bands from the face mask, you're still going to get a movement forward. Not you just prevent the movement down. But if you try to pull up this way, first of all, it will be very uncomfortable on the lips.
Right, because the elastics will literally be pushing and cutting into the lips. Yeah. And is part of the reason that you said to pull down, besides that's just the only thing that's really possible, is it because you stick by what you said, that you're only willing to treat class 3 patients with a face mask?
Well, it's the only place where it makes sense, right? So if somebody's, I just had that discussion with another patient. So again, it's always patient specific. So what we need to achieve in this particular patient situation. So we have the upper jaw that's deficient enough that I could treat it with the face mask. And if it's class 3, if the vertical is diminished, then you need to bring it forward and down, and it essentially creates a rotation of the lower jaw back a little bit or down, helping increase the vertical and solve your class 3 situation. Again, it's very patient specific, so don't think I'm doing that for everyone else. All right, sure. So if it's a class 3 short maxilla, then that's where you work. It's a really tall maxilla and the patient is gummy, by bringing the upper jaw more forward, I'll make it more gummy. It's a surgery case. You can't fix it with a face mask. If the patient is bimaxillary retrusive, means both jaws back, but the lower jaw is even smaller. And I just had a patient discussion with someone where he wanted to try a face mask to bring the upper jaw forward. And I told him, okay, we could bring the upper jaw forward, but what about the bottom jaw? How are we going to catch that up forward? So face mask is very situation specific. Where are we going to apply it? Where are we going to use it? It's primarily for class 3 cases where you avoiding surgery and when you could create compromise, which is acceptable both aesthetically and functionally. And it's patient specific, whichever way the pool goes.
Since you brought up surgery, I want to just ask you a few super quick questions about surgery. What do you think is harder to find? A really good MSE provider or a really good surgeon? Do you think surgeons are just as risky as MSE providers when it comes to their ability to screw things up if they're not, really on top of it?
I tell you the joke if I haven't told you already. You know what the difference between the oral surgeon and God? God knows he's not an oral surgeon.
God. Oh, you didn't give me a chance to answer. That's funny.
Essentially, a lot of oral surgeons have this ego, kind of a cowboyish. I know a couple of very, very good, extremely good oral surgeons, and probably, Mike Gunson would be one of my absolute favorites because he takes just as much of attention to every single little detail when he plans his cases. So when I have a case with him, everything comes out just right because he doesn't let anything go by. But it's sometimes the surgical preparation also depends on orthodontist. You need to accomplish all those little things. So the orthodontist could screw up, and the surgeon just works with what he's got. You have to pick a team of both oral surgeon and orthodontist. And, I've had patients who I treated orthodontically and they went to the oral surgeon that I would never work with, but just for insurance reasons or their own stubbornness, they decided to go someplace else. And the result was mediocre at best. And I have a couple right now that went to some supposedly big name somewhere in Europe, and I was not happy with that outcome at all. So,
Wow.
it's probably harder to find an oral surgeon, I would say.
Man, surgery really is a minefield, huh? You got to really be careful, and it's definitely not the place to cheap out.
You can't.
Would you say, let's say for a medium earning person, someone earning, $60,000, $70,000, $80,000 a year, they can get a free surgery through their in-state provider, or they have to cough up $40,000 out of pocket to go to the right person? You really think it's better to, it's really not right to budget on surgery? It's better to just pay once and cry once with the right surgeon.
It's I would say, I would look at it this way. You could cheap out and then it'll be a lifetime of regret, or you could regret once spending $40,000 and then enjoy the rest of your life in harmony and looking great. You take your pick. You want to cheap out and you take a risk of your face being screwed up? Sure. Or if you want to, you maybe want to invest some of your savings into making yourself feel and look better, so this way you could actually do better in your life. That's how I would look at it. And I'm sure there's plenty of good surgeons. Some are really incredible, some are good, but if they take their time to plan cases and execute cases, and they've had trainings and they've done thousands of at least hundreds of cases, I'm sure they know what they're doing. That's great. Well, on those insurance plans, they've learned it once in oral surgery program, and that's how they've been doing their entire life. Just to get it close enough. I don't know. That's not something I would want for me or my patients.
Yeah, that's very well said, Doctor. It's scary, but it's very well said, and forewarned is foretold, or foretold is forewarned. I think I've spoken probably with a dozen or more people unhappy with their surgery cases over the past year, and they're looking for a revision. I just could not imagine getting that done twice.
That's right.
I couldn't imagine it. Right. There's no amount of money you could pay me to do that twice.
Yeah.
Last question, Doctor. Go ahead.
There's a British saying my father used to say, we're not that rich to buy cheap things.
Because the poor man pays twice.
That's right. If you're going to go cheap on something, you're going to pay again for it. And that's true for everything, not just surgery.
That's well said. Your father was probably a very wise man. Was he also a doctor?
He always wanted to be a doctor. He still is a wise man.
If he's listening, then
he's
God
not
bless.
Listening, but yes, God bless his
Last question. It's a random MSE question. It's something that Dr. Yusefian brought up to me when I interviewed him, and it's something that's coming up with a good friend of mine now. when you split the suture and you start getting a diastema, this phenomenon of the front teeth in the mid-face here in this area coming backward. Is this something you've seen? Dr. Yusefian puts a wire coming off of the MSE to hold the front teeth forward during expansion. My friend is going through this now where he feels like his upper lip is sort of sinking in as he expands his MSE. Have you seen this? Do you have any comment on this?
Yes, I do. Well, it's just pure physics if you think about it. Well, first of all, when you do the expansion, the upper actually comes forward naturally. That's just how the pyramid sits inside the maxilla sits inside the rest of the head, and just naturally, just by splitting it, it comes more forward. However, if you think of the narrow arch, and as I'm going to widen it, see what happens with this? Okay, this is narrow and pointy, and as it gets wider, it flattens. So as you start getting this wider, this is just gets stretched. It's not going back; it just flattens. So I don't think holding the wire forward is important. I think it's just needs to be following that treatment, following the expansion. You need to design a plan of how you're going to maintain that arch form and keep things forward. And maybe that patient should have had a face mask.
So you think that the orthodontic part of the treatment can help if the front teeth do flatten out, that lip support can be reestablished using Invisalign or something like that in the orthodontic phase of treatment?
Absolutely. You can just use the same expander as an anchor to helping front teeth come forward.
And how would you do that?
Let's say usually in some of the patients where let's say in the class 3 patients where we expanded and now there is a lot of space, if you try to close that space conventionally, you'll actually retract the front teeth. You'd have to rush taking out the MSE because MSE locks the molars to the bone. So you could push other teeth forward and, to close that space without compromising the arch, arch shape. And then once everything's forward, you could remove the connection to the MSE, use something to anchor the front teeth, and bring the molars forward into that remaining space. So this way you could maintain all your arch position forward without ever sacrificing or retracting your front teeth.
Last question. I know I said last question 3 times now.
It's okay.
Truly last question. What do you think of this new MSE sort of analog device? What do they call it? The FME, the Face Genix maxillary midfacial expander, or whatever they call it, FME. I think.
It's got some nice features to it. I think the 3D planning looks credible. I have not tried it yet. I am going to, but it's just a variation of MSE. And if you don't plan it, it's not going to work.
It's not a magic bullet.
It's not a magic bullet. Nothing is.
It doesn't have a brain.
Like we talked about, it's stupid.
Right. It doesn't go in your mouth and then adapt to your maxilla and then figure out exactly what it needs to do to get you split perfectly. It still needs to be all the same things that you have to do to plan an MSE.
Absolutely.
You have to do with this.
Absolutely. And they make some claims that I yet to see it happen, because my concern is all 3, it's based on 6 TADs, 4 or 6. So, but they're all along the midline. And they say because they screws fitting so tightly into the framework, they're not going to drag. But believe me, the screw will drag even if it's held straight. It will drag through the bone. So I'm thinking if it's placed incorrectly into very, very narrow maxilla, it will just not expand. It will fail. So it's just, I've seen actually just a good friend of mine installed even custom expander, and they all 6, even 8 TADs were all along the midline in a very narrow palate, very thin palate, and they all just dragged right through. So it needs to be customized, thought through. Sometimes we need to add some TADs on the sides and to engage bone where there is bone. So, but we'll see how that FME works.
Yeah, you don't see it as a total replacement for PIEZO or as a replacement for any of the skills and techniques that are really required to navigate successfully through MSE potential downfalls.
It's just a different tool. If you don't plan it, if you let someone else plan it for you, you're going to have a mistake.
Yeah, it's like Windows versus PC. Some say, you need a a Windows versus Mac. You need a Mac because the Mac is, you know, da-da-da-da-da. But at the end of the day, whether you're editing videos on your Mac or your PC, you still need to edit them right and make good content. And really, at the end of the day, it's just a tool.
That's right.
And they basically do the same. They basically do the same shit.
Exactly correct. They do the same shit.
All right, Doctor.
I'll leave you with the last little tidbit. It's one day a friend of mine bought a really nice revolver, and I went to the range. And he's a pretty decent shooter, but he was all over the place. And then we went to this guy who's a gunsmith and a former shooting champion from Soviet Union, and he took that same revolver, put the target 25 yards out, and put all 6 bullets into 1-inch target. And he said, "That's not a gun, that's a shooter."
Yeah, right.
So
it's about the shooter.
So if you know what you're doing, if you're controlling the steps, doesn't matter what you use. You could use, I don't know, monkey wrench, and you still accomplish what you need to accomplish.
Right. Maybe the MSE is like a little snub-nosed revolver where it's very difficult to shoot, but a good shooter can still put the 6 shots in a quarter.
You got it.
Maybe the FME is more like a Glock 34, like full-size 9mm, heavy, low recoil, right?
Yeah.
And it helps, but guess what? If you put the Glock 34 in the wrong hands, they're still going to miss every time because no matter what you do, shooting a handgun is very difficult.
That's very true. Now we got to get gun advocates or opponents commenting to this video.
No, what's going to happen is we're going to get flagged by YouTube.
Or that, yeah, I know, right? And delete that part.
Okay, maybe I will. I appreciate your time, and I will be seeing you soon for my own appointment.
Awesome. Talk to you soon. See you soon.
Okay, Doctor.
Enjoy your day.
Thank you so much.
Pleasure.
You too.
Thanks.
Bye-bye.
Bye-bye.
You can see the skull with the diastema from the MSE.